Welcome to the Landy Peek podcast. I'm your host and friend, Landy Peek, and I am thrilled to have you join me. In each episode, we will explore what makes life truly fulfilling: happiness, deep connections, and self-discovery. Together, we'll uncover that happiness is not a destination, but a way of living. Now, let's dive into today's episode. Today we have an incredible guest, and it happens to be her very first podcast, which I'm so excited. We have today Abby Seufer, and she is my personal provider and literally the woman that changed my life when I thought I was falling apart. And I went in, and I've told the story before on the podcast. I went in and I'm like, oh my gosh, what is happening? And she gave me a term to what was going on, and that was perimenopause. Abby, I am so thrilled you're here. Can you tell our listeners a little bit about yourself?
Thank you, Landy. Yes, so I am a PA. I have worked in women's health for my entire career, 20 years, and recently just kind of transitioned from general OBGYN practice to more like perimenopause, menopause. So sort of focusing on that. That's my niche. That's where I'm focusing all my energy and research. And that is my demographic of all my clientele. And it's been really fun to see women like you and me and all the people that are kind of experiencing the same thing.
It's incredible. And before we got on the podcast, I was saying how much I share your name because of how it really changed my life. And I'd love to start with, what are we talking about when we're talking about perimenopause? What are the symptoms, and sometimes maybe not obvious symptoms, so that as we are listening in, we can start going, oh, that's me. Oh, that's me. And know that this episode is exactly what you need.
Yeah, that's a great question. So I think, we're pretty well informed as far as menopause. And the definition of menopause is 12 months without a period. And it's a single day in a woman's life where you've gone precisely 12 months without a period. And then anytime after that, you're considered postmenopausal. And I think when I was in training, and most of the medical providers have had this similar training, we have our reproductive years, and then there's menopause, your period stops and you have hot flashes, and that's the end. But what I found as I'm kind of working my way through my career is there's this whole subset of women starting in their 40s that are still menstruating, and many of them still menstruating very regularly, but they're having all these symptoms, and these symptoms sound like hormone symptoms, and they can be very vague, and they can be symptoms of a million different other things. I mean, the ones that I hear more frequently would be fatigue, insomnia, irritability, anxiety. I have women who have never had anxiety disorders and suddenly are presenting with panic attacks that they've never experienced before. They've been to the ER thinking there's something wrong, cardiovascular wise. And it's like, no, this is perimenopause. And I think because the symptoms are so vague, and a lot of times these women are still menstruating, that it takes us a while. We don't have a lot of very tangible symptoms. So sometimes it takes a few years of these symptoms like not getting better, not going away, and in fact, compiling more symptoms. Oh, I should throw in weight gain, low libido. Those are common ones as well, irritability. So those are the kind of the biggies. But about the time people start to recognize menstrual changes, I think that becomes the most tangible symptom that they're thinking, oh, maybe this is hormonal. And so we've coined this term, and I don't know where this term came from, and I don't even know how long it's been around, but I never heard it in my training. But we call it perimenopause, and it lasts about 10 years before you're in menopause. And it's a very turbulent time as far as hormone fluctuations and symptoms that we just haven't given enough credit to. We're all familiar with menopause. There's treatments for menopause, but there's this really turbulent time that feels really chaotic, and that's perimenopause.
It absolutely feels chaotic. And I had heard prior to knowing you and coming in and dumping on you of like, oh my gosh, my life is falling apart. I had heard of menopause. And so perimenopause was not even on my radar. And I had been a women's health pelvic therapist. It should have, quote unquote, should have been on my radar, but it wasn't there. I was thinking, this is not menopause. I was still having my cycles really regularly. I all of a sudden was having migraines. I was having exhaustion.
Big
I was a lot more
symptoms, yeah.
irritable. And it's like, oh my gosh, to the point I'm feeling like I'm going crazy and I'm not being able to function as the exhaustion really hit in of like, just getting the kids up, getting to work, doing my thing. At the end of the day, I'm exhausted. I want to just take a nap. I don't want to get off the couch. And you're like, this is what it could be. Let's try some things. And hearing that there was something we could do was huge. So, can you share just a little bit about what are our options when we're literally feeling like we're falling apart and going crazy?
Yeah. So, I mean, there's a lot of options. And number one, I mean, we have to give our body what it needs, and it's not going to have the resilience that it used to have. So, we sort of have to be a little bit more dialed in with our diet and our sleep pattern and really recognizing our stress management and all these things. And I think for the most part, women are really good about that. We want to feel better, we want to help ourselves. So, I feel like by the time people come in to see me, we're not starting at, these little lifestyle changes. They've tried all that. They've tried all the vitamins. They're on 10 different supplements. There's so many different things. Maybe they've seen a few providers. They've had, a blood count and they're not anemic, or they've had their thyroid checked for the fatigue and the migraines and the weight gain. And all of this looks normal, but I think we're not looking at it through the right lens. And so I think a good approach is, number one, we do need to dial in the lifestyle stuff because we just don't have the resilience we used to have. We can't eat terrible food and expect to feel good and expect that we're not going to gain weight. We need the right balance of nutrition. We have to watch cortisol and insulin levels and all these other things that play a role. But I am a big advocate for still testing hormones. And that's very controversial, especially in the conventional medicine world, because testing hormones it's a moving target, right? We know our estrogen, our progesterone, our testosterone changes every single day in a 28-day cycle, but it also changes throughout this decade. So we don't always know what numbers we're looking for, but I do think if we look outside the normal ranges, because the normal ranges, they're too big. We get the normal ranges because we test a bunch of people and we put 90% of them in this range that we call normal, but there's also something called optimal. And so if we look at these hormones and we kind of really listen to our patient, and we can kind of scrutinize over these numbers a little bit, but it takes some training and it takes some confidence, and it takes having done this a lot of different times and hearing stories and seeing what hormone levels kind of relate to symptoms, whether or not these hormones are in the normal range. That I usually do add in some bioidentical hormones. I usually start prescribing early in the process. Women in their early 40s, we know their levels are not what they used to be at 25, 35. They're still normal levels, but they're not optimized.
Yes. And I love the focus on optimal, because a lot of we're in normal range, but you're like, but this isn't optimal for making you feel good. And so we went on the journey of hormone replacement therapy. And what I expected was just to come in and get estrogen. But that wasn't where you started me. We started with progesterone. And that was a real surprise because I hadn't even clued into progesterone and testosterone and how those are going to shift. And estrogen was way down the line. Can you share a little bit more about how you start looking at hormones and bringing them back in when people need them?
Yeah. So it's true. I mean, we're going to test estrogen. We're going to check progesterone, testosterone. I check something called DHEA. It's actually made by our adrenal hormone, but our body can use it to make a little estrogen and a little testosterone. So it's a precursor hormone. We don't want the ingredients for the hormones or the precursors to be low either. In general, there is sort of a sequence of events that happens over the course of perimenopause. And the first thing that really starts happening is testosterone starts declining in our mid-20s. And I have a really good graph that shows testosterone just kind of a very slow, gradual decline starting about our mid-20s. And what I tell everyone is if all of our hormones did what testosterone did, which is just gradual decline, very linear, I don't think we would really be that focused on perimenopause. I think we're willing to accept that we're going to feel different in our mid 40s than we do in our mid 20s. And if it's sort of gradual and it's a natural part of aging, I think women are willing to accept that. But unfortunately, what happens is we have this really steady dose of progesterone for about 3 decades. And then starting somewhere between 35 and 40, that progesterone level falls off the cliff. It's not a gradual decline, it just starts plummeting downhill. And what we'll see when that starts happening is women are presenting with anxiety and irritability and insomnia. And then we'll start to see periods get heavier and we'll start to see breast tenderness, like what you had in adolescence, come back. And
Exactly.
we'll start to see that. And that's the very first hormone change that feels really dramatic. And so if women come in with those symptoms, even if their progesterone is normal, just knowing that they're 42 and this process starts happening at 35, I'll add back a little progesterone. Well, meanwhile, estrogen stays fairly steady. It's gradually dropping a little bit, but about our mid 40s, estrogen really gets really chaotic. And instead of just a gradual decline, which if something is on the downhill slide, it's much easier to support that. We give a prescription, we just have to increase the dose every now and again. But estrogen is very chaotic. We get these peaks and we get these valleys. We have highs and lows, and it's very unpredictable and it's very chaotic. And that gets a little more complicated. So I usually try and wait to add back estrogen until we're having more of the lows than we are the ups and the downs, because we could add back estrogen too early. And you're going to have days where you're making more estrogen than your body's ever made before because it's so unregulated during this time. And now you're over estrogenized and you don't, that doesn't feel good. You have headaches, you feel emotional, we feel tired, we feel bloated and swollen. So adding the estrogen back gets a little complicated and it truly is trial and error. But, my sequence of events generally, and it does vary from patient to patient, is we start with the progesterone. And then a lot of times we either go to estrogen or testosterone. It just depends on level. That's usually how I proceed through.
I love that. And it really does help. As I've been working with you for years now. And
Mm-hmm.
so it was, coming in, and I totally forgotten about like breast tenderness. And yes, as I'm thinking back to my very first time when I was coming, just as it was like my annual visit, coming in just annually, not thinking this, dumping on you of all these things are going on, that progesterone helped. But then it was, I want to say a year or two later, and then we added in testosterone.
Mm-hmm.
And we were just talking about before, I think it's time to start maybe playing with some estrogen as symptoms are shifting. And now this is a 4-year process that we have been working with this. And I love that we're trying things slowly, that it's bringing it in and not this all one swoop.
Mm-hmm.
There were also supplements that as you tested blood work and you did the Dutch test, that we started bringing in that helped before we were adding in a lot of other things. So you talked about those precursor hormones. Can you explain a little bit more about that?
Yeah, so we have some precursor hormones. So our body will make a couple different things from cholesterol. And from these cholesterol molecules, it'll make pregnenolone, it'll make DHEA, and most of our hormones get made from these common cholesterol molecules. So another nice way to support the body is if we're looking sometimes at DHEA, and if that's low, that's just another resource for your body that as the ovarian function declines, we can add a little DHEA and make sure that's in the normal range. So then the body has the liberty to, inside each cell, determine if it wants to make a little estradiol or if it wants to make a little testosterone with this molecule. And I think we have to sort of look big picture. I do think providers are doing a better job in conventional medicine of looking at and prescribing estrogen and progesterone, and they're even getting better at testosterone, but there's so much more we need to look at. So we do need to look at the DHEA. We need to consider something called pregnenolone, which is sort of a master hormone. And I've been doing this deep dive into cortisol and insulin because I've learned that, as we're managing and optimizing these sex hormones, there's still something that's just not flowing right. And it's usually insulin and it's usually cortisol. So I try to look a little bit more big picture with some of that.
Can you go into the cortisol and the insulin?
Yeah.
I don't think we've talked about that.
So we probably haven't talked about that because when I was working in conventional healthcare, like there was no way I was going to be able to bring in insulin and cortisol, right? We don't do anything with those hormones unless you have diabetes or unless you have two very severe cortisol problems, Cushing's disease or Addison's disease. No one really recognizes the role that cortisol can play. And so it's kind of, as I've been outside the realm of conventional healthcare and more just digging into the perimenopause space and digging deeper and just trying to really look just large, like what are the other influences here? Because sometimes adding estrogen, progesterone, and testosterone back doesn't solve all the problem. So if we look, there's a hormone hierarchy, and it looks kind of like a pyramid. And it's basically the importance of the hormones as they influence one another. And so at the very bottom of this hormone hierarchy, we have insulin. And this becomes important because we naturally get insulin resistance as our estrogen levels decline. So we can add back some estrogen, or maybe we don't add back estrogen, but now we have this insulin resistance, which is leading to weight gain that no one's ever addressed with these patients before. So that's the insulin component. Then above it, we have cortisol. And cortisol is kind of our keep us awake and alive hormone. And there's a lot of influences there. And cortisol is also made from the same primary cholesterol molecule that's going to make progesterone and some of our other hormones. Well, we know that cortisol is one of our stress hormones. So if our body feels this abundance of stress and suddenly it has to use all those resources to make cortisol, we may see some additional dysfunction in the sex hormones that we weren't expecting to see. And I think it's important to recognize that we're all living in fight or flight. Right. I think you've touched on this before in some of your other podcasts, but life is complicated and we wake up and we feel like we're being chased by the tiger. And that can cause cortisol dysregulation in acute circumstances, but then long term, we'll see some other dysfunction with the adrenal gland. And so now we have this other major hormone that's influencing our sex hormones besides just age, influencing our sex hormones. Thyroid is on the pyramid. It comes next. Very common for women to have thyroid disorders. Especially as they get older. And then we have the reproductive hormones kind of at the top of the pyramid. So if we're only looking at the top of the pyramid, we're missing so much opportunity, especially for fatigue and weight gain. And that's why I started digging into those other hormones, because those are the two symptoms that were still bothering people, even though they were on HRT and their levels looked fine. And it was like, what else is going on with these women? And I think by the time you see the same pattern, hundreds of times. It's not just the one patient that's like really difficult to treat, that's refractory to everything you've ever tried, and that person has always been that way. No, it's everyone. It's almost everyone. So that's kind of why I started digging into some of these other things, which is new for me. I mean, it's really been in the last few months that I've really paid more attention to that too.
That's incredible because it makes sense if you're looking at it as a pyramid that we are talking about and really looking and highlighting that top of the pyramid.
Yep.
But if you're not looking at that foundation and
Mm-hmm.
coming into stress and cortisol and what's going on at that bottom level and
Mm-hmm.
how that is the foundation for the rest, I love that you've dove into that and really
Mm-hmm.
found that this is the one of the missing pieces. I mean, just coming in for hormone replacement therapy and learning about what's going on with our bodies and that we're not going crazy and we're not falling apart,
Yeah.
but that there's so much more that we can do and how we can support ourselves.
There's so much more. And I think it's important to recognize that perimenopause is as much a metabolic disorder as it is an endocrine hormone disorder. And I think that's the key that's missing for most providers from their understanding, because it's really hard to get the information to make those connections. So, but that's kind of the key for people for longevity and for health.
I know one of the things that we talked about in just fears in coming in and doing hormone replacement therapy, because as you were sharing about it, I'm like, but what about increased risk of breast cancer? What about increased risk of like all of the kind of fear mongering that has been in the past? And you're like, that's not the case anymore. Can you
Yeah.
share a little bit about that? Because I'm sure I'm not
Yeah.
the only one that was like, I've heard a lot of bad things about this.
You're right. There are a lot of bad things, and it's really unfortunate because I think there's this whole generation of women that weren't offered HRT, and there's a whole generation of women like myself that didn't get any education in school because it was just like, oh, hold off. We don't even know what this data means, so we better not teach anything right now. And even if we look, I mean, most people at this point are familiar with the Women's Health Initiative study. If we look at the Women's Health Initiative study, which did show there was a slight increased risk for breast cancer in one group, and I'll talk about that in a minute, and there was an increased risk for stroke with women using estrogen. But even with those increased risks, overall, there was protection for a lot of people for brain, heart, protection, against symptoms like hot flashes and those types of things. So the problem with the Women's Health Initiative study, well, let me back up a little bit. If we look at the history of hormone replacement, it probably started in the 40s and 50s with bioidentical hormones. And women were doing bioidentical hormones and they were feeling better. And there was thought that adding some estrogen back to women as they transitioned into menopause may actually protect them from cardiovascular disease. And cardiovascular disease being the number one cause of death for females, the pharmaceutical companies got interested in this and thought, well, wait a minute. If this is protecting against the number one cause of death for women, we want a piece of the pie. And so they started developing some options because bioidentical hormones can't be patented. Mother Nature owns the patent. You got to change the molecule if you want your own patent. So some of the companies came in and we ended up with a couple new common commercial products. We have Premarin, which was a combination of 8 to 10 equine or horse estrogens, none of which looked like our own estrogen. And then we had a synthetic progestin called medroxyprogesterone, which we've had for a while in birth control. And it's actually a birth control I rarely use because it made everyone fat and crazy. So the fact that they chose this progestin to, be the option for this big study is kind of mind-blowing to me. But nonetheless, they were checking mostly if they give women the Premarin and they give women the Provera, was there a decreased risk in cardiovascular disease? And there were 3 treatment groups. There was a group that had both the the estrogen and the progestin. There was a group that had had a hysterectomy. And if you don't have a uterus, you technically don't have to have the progestin to protect your uterus against the estrogen. So this group only had the conjugated equine estrogen, and then we had the placebo group. When the study stopped prematurely, it was for a couple of reasons. Number one, there was an increased risk of stroke in the treatment groups. And number two, they thought there was an increased risk of breast cancer associated with the treatment as well. And when we dig back through the data, we actually got some really good information that we still use today based on the study. And one of the things we learned was, okay, oral estrogen increases the risk for stroke. So now we use transdermal, absorbed through the skin, things like patches and creams and gels. And then when they looked at the breast cancer data, it was only in the group that had the Premarin, the estrogen combination, and the Provera, which was the progestin. That group did have an increased risk for breast cancer compared to the placebo group. The risk was 5 cases of breast cancer per 1,000 women, which the baseline risk is 4 cases per 1,000 women. So that's the risk if you're not on HRT. And some of the scientists looked at that and panicked and said, that's a 20% increase. So now we have the data that says HRT causes a 20% increase in breast cancer. So HRT stopped. It just stopped. But the absolute risk was only 0.1%, because if you're looking at a really low risk to begin with and it increases by 20%, your absolute risk still isn't that high. And it's taken 10 or 15 years to look back through the data and convince people that, like, number one, if we use the bioidentical hormones, which we were using originally, the risk is lower of all those things. But number two, if we don't do oral estrogen, if we don't use the synthetic progestin, the HRT is much safer.
That's incredible. And it was in sharing that I was like, okay, let's try this, because there had been so much fear around it. And it's like, I really don't want to continue living like I'm living, because this is really not fun. And I don't want to increase risk of breast cancer, especially since my mom had breast cancer. So it was really in the forefront. And then hearing how HRT had so many benefits for longevity in decreasing risk of heart attack, in decreasing risk of dementia. Can you speak more to the benefits and how taking and starting HRT really can transition what your life long-term looks like?
Yeah, I mean, it's really important. And I think the main thing to consider is, if we look at the year January 1st, 1900, I think the average life expectancy for a female was like 49 or 50.
Wow.
And so if your reproductive organs failed at 50, it's okay. You're at the end of your lifespan. But we have this situation now where we have this long life expectancy. And I think for females, it's now 83, but probably for you and I mean, it's just continuing to extend. But this life expectancy of our ovaries hasn't increased at all. And we're really the only species on the planet that we know of. I have heard there's one type of whale, maybe this happens too, but we're almost the only species on the planet that has a life expectancy of about a third of our life after these reproductive organs fail. And when we think about what hormones do, they're the little messengers throughout the body that coordinate the communication of the organs and the function of the organs. And we're probably not designed to live without these. And so there's a lot of things we've noticed that women are at increased risk for as soon as they're in menopause. And it is things like dementia and Alzheimer's, cardiovascular disease, which historically we have much lower rates of cardiovascular disease than men until menopause, and then our risks are equal.
Wow.
Osteoporosis. So there's a lot of things that, we recognize that the hormones can improve, but we probably don't know all of it. We have hormone receptors for estrogen, progesterone, and testosterone in every single organ of our body. We have them in every cell of our body except red blood cells. So these things do a lot for us as far as communication and coordination. and our body relies on it. And we get hot flashes and we get frail skin and we get these things because our body's trying to tell us it doesn't have something that it needs. And so we do have a lot of data showing, there is probably some protection from Alzheimer's, dementia, cardiovascular disease, and osteoporosis. And those are the three biggest causes of morbidity and mortality for women as we get older. But there's some newer data. There have been several small retrospective studies that have shown estrogen is protective against colon cancer, which, by the way, we're more likely to die of colon cancer than breast cancer. So that's big. There's probably some protection against things like autoimmune disease, arthritis. If you have arthritis and your joints hurt and your body hurts, you don't move your body. Now you have worsening insulin resistance. Now you have obesity. So it just kind of perpetuates if we're not addressing the root cause of the lack of hormones.
Right, which is incredible. So as we're looking at now, we are living much past when our reproductive organs are kind of failing and shutting down on us. When we start something like hormone replacement therapy, is this now a lifelong thing? Or is this like at some point we start weaning ourselves off? How does that work?
So that's a really good question. And I get that question a lot. And this will be very controversial because we still don't have the long-term data. We have a lot of little studies, and that's kind of what we have to go off of until we have more data. We do have safety data and a lot of little studies, but as far as like the timing for when we need to stop hormone replacement, it's very individualized. And my personal opinion is there seems to be a benefit until at least age 60 or 65. And anytime we are prescribing these types of medications, we're looking at the individual as a single person, and we're looking at their risk and their benefit ratio. And we obviously want the benefits to outweigh the risk. And for almost every single person, the benefits significantly outweigh the risk for HRT, especially if you start early in the process. Well, there is a natural piece of aging that's somewhere between ages 60 and 65. The cells aren't going to work the same, whether we have hormones on board or not. They may not have the architecture to be able to put the hormone receptors out on the cell effectively. So there may come a time where the benefits no longer outweigh the risk, and not because the hormones have become more dangerous. It's just because the body is no longer using the hormones. So there's really no benefit. And we think that's somewhere between age 60 and 65. So with my patients in that age group, where we're trying to figure out, is there still a benefit to you taking this? My rule of thumb is, let's ask the body if it's still using these hormones. And so we stop the hormones cold turkey, which makes people very nervous. And some of them feel the exact same. And if they feel the exact same when they stop the hormones as when they were taking the hormones, they don't need the hormones. Their body hasn't been using them. There's no benefit. But in the other group of patients, if they stop the hormones and their fatigue comes back and their joint pain comes back and their hot flashes come back, and these things come back kind of immediately. We don't have to wait months. We can figure it out in 2 weeks. Those people go back on the hormones. It's fine. Your body's still using it. You're still benefiting from it. There is not a deadline for when you have to come off of it, which is different than what we were taught years ago. And so I think this is the part of HRT that's TBD, that you and me, our generation, is going to figure this out for people. How long do we stay on them?
Which is really incredible as you think about that we are like leading edge as we are leaning into this, and that, my daughter's 10, that when she hits her 40s, we'll have a lot more information for her. And we can have those conversations with her. I mean, I'm already having the conversation as she's pre-puberty and I am perimenopausal, like, we're some big emotional outbursts right now.
Yes.
But talking about what this is and what we can do, unlike our generation, me in particular, where as I started talking about this and started talking about perimenopause, the women in my family, for the most part, had never experienced it because symptoms started and they got hysterectomies.
Mm-hmm.
So, like, when I talked to my mom, she's like, I don't know. That was never a thing. I started having a lot of symptoms. I had a hysterectomy.
Mm-hmm.
Okay, so there isn't this anecdotal information coming in of like, oh, this is what this is. I mean, we know this about puberty. We have a lot of information as we're coming in, prenatal, postpartum. There's stories that we can hear and things that we can share. And this, oh, yeah, that happened to me. And
Mm-hmm.
at least in my experience, there's no stories. So it's like,
Yeah.
oh, well, we just took it all out. And
Yeah.
that was it.
So that's true. I think they were overly aggressive with hysterectomies for the generation ahead of us. It was kind of like if you're done having babies, you kind of just get a hysterectomy for anything,
Uh-huh.
right? So we don't do that much anymore. But I also think, and I did not make up this theory, but perimenopause is probably kind of a new thing, which is why it's a term we haven't really learned before.
Yeah.
And if we think about it, there's a lot that our bodies have been exposed to that generations before us haven't been exposed to.
Right.
And there's a lot of endocrine disruptors that
Mhm.
the other generations weren't exposed to growing up. I mean, the biggest thing that I think of is, we were all children in the 80s. Like, think of the food pyramid, and we're supposed to have 12 servings of carbohydrates
Yes.
per day, and we're supposed to be afraid of fat. So now we're supposed to be increasing our intake of carbohydrate. Around the same time, the carbohydrates are becoming a lot more processed, and there's
Right.
a lot more glyphosate, and there's a lot more preservatives. And now we have all these artificial flavors and colors, and everything's in a package. But that didn't seem to matter for the food pyramid. It was just you need your 12 servings of carbohydrates, and we were afraid of fat. So we weren't eating the fat, which makes up the cell layer for every cell in our body. And instead of fat being added to food, sugar was added to food. So I think metabolically, we're already very inflamed.
Yes.
Gut microbiome is probably really imbalanced. So
Mhm.
we're already in this very vulnerable situation that other generations were not in. And now you throw in the hormones, and that's why we're so much more symptomatic.
Ah, that makes so much sense.
Yeah, it's so fascinating
It,
because I've thought through this a lot when I'm like, why did I never hear of perimenopause? Why does no one mention perimenopause? I don't think it existed. And like I said, I didn't make up this theory. I've heard bits and pieces of these theories at conferences that I've gone to, and it just makes so much sense.
it does as you're talking about it. And as I focus more on how I can support my daughter, a lot of kids are starting puberty earlier and earlier. And so for my daughter, that's something I've really been more aware of and looking at what we're putting into her body, how we're really structuring activity and things like that so that we have puberty hitting more in a delayed rate versus the early onset, which some of her friends have a really early onset of puberty and at fourth
Mhm.
grade are having periods versus, maybe starting breast buds at fourth, fifth, sixth grade, somewhere in there. So we're having conversations early as she's having friends that are already starting puberty. So I've been very conscious and aware of how diets and our environment and life experiences are impacting that. I had never linked it to what's going on with me.
Yeah, that's interesting. Yeah, it's the same thing. We're both, your daughter being 10 and us being in our 40s, we're in a very vulnerable place, but we've had this low level of inflammation and dysregulation probably for a long time that's accumulating. And that's why perimenopause is so dramatic. But these poor kids, and same with my kids would tell you, I obsess over the food dyes, the fragrances, the glyphosate, the plastics. It
Mm-hmm.
doesn't mean that my kids do anything right that I ask them to do, but I still obsess over it and lose sleep over it because we've gotten ourselves into a really tricky situation with all of that, and it's hard to get away from. So
It
it's
really,
good to be, to acknowledge that. And I think you're right. The more you can do organic and natural, the better for the hormones, right?
right, which is huge. And as I've been so conscious of her and, being the mean mom who, we don't get all of the food dyes.
You and me both.
So those are the big treats because that's not regular diet, which,
Yeah.
does make things a little bit trickier as you're parenting. But that's also how I'm eating and
Hmm.
being much more conscious. But I really didn't tap into taking all plastics out, really focusing on organic foods until I was trying to get pregnant.
Yeah.
Then, I mean, but that was in my early 30s that I
Yeah.
had 30 years of, and I mean, I had typical 80s diet of lots of cereals and white
Yes.
margarine and like the whole thing
We
of
all did.
my diet. So it wasn't until I was an adult that I'm actually starting to think
Hmm.
about what I'm eating and what I'm consuming in plastic wise, just with
Hmm.
containers. And so this is just like the aha moment of just,
Yeah.
oh my gosh, you're right. This is the missing link. And probably I had written it off as they all had, generation before me had hysterectomies, but there is a heightened inflammatory rate in our systems that
Yeah.
they didn't experience for
Yeah.
the same length of time. They went through the 80s as well, but
They went to the 80s as well, but
it
they
was,
weren't eating the packaged snacks probably that we were eating as kids.
yes. So it makes such a huge, huge difference.
It's really interesting to think back. And I mean, it kind of makes, personally, it makes me a little mad. Like, why aren't we more protected? Like, where is the oversight and the regulation? Because I think we're starting to recognize the impact that some of this has.
Yeah.
Um, but really, as far as perimenopause, I think that's why we haven't heard about it from a different generation. They didn't have it.
That makes so much sense. I would love to tap into, as you're talking about getting support, how does the listener find a comprehensive provider who is really going to look at this whole system like you do and be able to find all these moving pieces to
Yeah.
really get that support?
So that's also a very good question, and it's not going to be easy to find, and it probably will be nearly impossible to find in conventional healthcare because we're kind of stuck with protocols that are a little bit outdated, a little too conservative, and that's what we have to go by in conservative healthcare. But there are people that are getting better and better at it. So there's a couple things. If you go in for your annual exam in your 40s and you're getting screened for some of these questions and symptoms, I think you have a really good provider because most providers are not going to want to dive into that. And they're hoping when they see that you're 42 years old and you're coming in for your annual, they're just really hoping you don't mention anything about the H word, the
Uh,
hormones, because they just don't have the tools. So if you feel like your provider is screening and asking questions and curious as to, are you having some of these symptoms? I think that's probably a good provider. Hopefully they have some options as far as testing and whatnot to follow up with you.
mhm.
The other thing is, I don't like when I have women who come in and they've felt dismissed, but they also have providers that just won't test their hormones. Like, women are pretty in tune with their body. And I think if we listen to women, that's going to be 80% of the information we need to help them. And the other 20% is maybe knowing how to interpret a test, maybe being able to give some treatment options. But women have already done the research. They've thought about this. They've waited forever to come in for their appointment. So they've really thought about it and they've done their research, and there's a lot out there. And so if they're asking to have their hormones tested, it's probably something hormonal that's going on in their body. And I think the more you can do with that, the better. So if there's a provider that does a combination of blood work, or that does blood work at two different times during the cycle, or that does some, urine metabolite testing, the more in-depth hormone testing that's offered to you, I think the better care you're going to get. Because just testing serum maybe once a year, which I see a lot, people coming in, oh, I've had my hormones tested once a year. It's not that helpful. But the more people come in with and the more testing is offered to them, I think if they have a provider willing to order and interpret some of those tests, they're on the right track.
That's really awesome to hear. Because one of the things that you did offer me was different ways to test. And so we did the Dutch test and we did some blood work, and you're looking at specific times in the month that we're doing the testing so that we're really not just like, oh, here's one day, but
Mhm.
we're getting a better snapshot of what's going on.
We are getting a better snapshot. And because these hormones are a moving target, one of the tests that I like to do is a urine metabolite test. And it gives us information over the course of like 24 hours versus one moment in time. But the other part of the puzzle is we can do blood and we can see how much hormone is available for the body to use.
Mhm.
And a lot of times in perimenopause, that's going to be a normal amount of hormone, right? Normal in quotes. But the other thing we can do is we can look at how the body's utilizing the hormones. And sometimes we can clean up the pathways that the liver sends the hormones down. This can
Mhm.
get really complicated. It's a lot of biochemistry, but we can recruit the hormones to be used for the beneficial stuff and away from some of the other things that hormones can end up doing. And that way, without even giving you hormones, women have this perception that they feel better and they feel that their hormones are more balanced, and we haven't even given them hormones. We're just using what's there, but we're not wasting it down pathways that don't serve the person's health.
I love that was a huge thing for us when we first
Yeah.
starting some of the supplements. When you did look at all my testing results, going, ooh, estrogen is traveling down a way that we don't want it to travel. And
Okay.
we want to bring in, I think you did DIM,
Yep.
bring back, where we want it to go. And so
Yeah.
I've forgotten about that early on conversation in really tuning in to how we can just use what we have in a better way.
Yeah. And that probably bought you some time, because how long ago did we do that test? A year?
It was I can't even remember the time frame now. But yeah, it was the very first time that we had come in and I was talking to you about it. We did that test. And so
Yeah.
early on,
So it's probably been a couple years
at
that
least 3 years, we've done
yeah,
that.
you've been able just to use, your own hormones still, but
Mhm.
feel like they're working for you a little bit better. So,
Right. Which was huge.
yeah.
So as we come to a close today, is there anything that you would love our listeners to know and anything you want to share before we're done?
So, I guess yes. The most important thing is just if you feel that something is wrong and you don't feel good, keep advocating for yourself. And I know that can be exhausting, like trying different providers and looking at different avenues. And yeah, there's a lot of online places, but they're probably not looking holistically. But, sometimes that type of care is better than no care, which may be the only option for some people. But just keep advocating, because there's a lot of information that we can use to help women in this stage of life. And I think the better relationship you have with your provider, the more frequently you see them, the more you're doing testing, I think the better control you're going to have over this. And keep in mind, it's probably a 10-year process. So this is not the rest of your life that we need to be testing and treating and testing and treating, but it's going to make this transition, which should be a really great time of our lives as our children are getting older and we're settled in our careers. We really truly should feel better. And there's data out there and there are providers out there. So just keep advocating. Find the right person for you.
Yes. And it sometimes it is that guesswork and hopping providers and being okay to hop providers to find that person that is going to listen, to find that person that will deep dive with you.
Yeah,
Because it's worth it when you find it.
it's worth it, and if you have to change providers, it doesn't mean that the provider you were seeing is a bad provider. They're probably really knowledgeable at some things, but
Mhm.
this is a really tricky thing that we don't get a lot of education in. So it's going to take a few tries to get to the right person, probably.
Oh my gosh, Abby, thank you so much. This has been such an incredible conversation.
Thank you, Landy. It's been fun.
I hope that listening to Abby has helped you as much as she has helped me in finding hope that there is help if you are struggling with perimenopause symptoms, because there is help, and it really can change how you're showing up in your life and how you're feeling. So find the provider, use the resources you have, and really keep advocating until you get the care and the support that you absolutely need. And because I think it is so incredibly important for you to hear, you are smart and you are brave and you are kind and you are loving and you are making a difference in this world just by being in this world. And I am so grateful that you are here in my life. I do love you and I like you. And I wish you all the happiness that today can bring. We'll talk to you on the next episode. Hey, before you go, just a little bit of legal. This podcast is designed for educational purposes only. It is not to replace any expert advice from your doctors, therapists, coaches, or any other professional that you would work with. It's just a chat with a friend, me, where we get curious about ideas, thoughts, and things that are going on in our lives. And as we're talking about friends, if you know someone who would benefit from the conversation today, please share. Because I think the more that we open up these conversations, the more benefit we all get. So until next time, give yourself a big hug from me and stay curious, because that's the fun in this world.